So next up, I'd like to invite to the podium Dr. David Roberge from Montreal. He's going to walk us through a technical innovation in the delivery of radiotherapy at his centre.
We're going down the other spectrum of complexity. It's quite a pleasure to be here. My main disclosure is I'm a radiation oncologist. That's all I do. I can't offer the patients surgery if they come and see me, but I do work with very pleasant hand surgeons. We'll talk a little bit about radiotherapy in my context and then what we're here for today. So we offer 3 of the techniques for radiotherapy. So the superficial radiotherapy, which is convenient because it's a relatively simple device, but you don't get to see in 3D what you're doing. Definitely gives higher bone dose, and it doesn't deal well with patients that have curved hands. The electrons, we feel, has the lowest total amount of radiation to the patient. It does take a long time to set up, and it's not ideal for curves, and it is, with the photons, a more expensive device. The photons give a very homogeneous dose, is what we deal with all the time, but you do treat probably a larger proportion of the hand with this technology. So as we saw, I think in one of the prior presentations, when you treat patients with higher energy electrons, the first layer of the patient doesn't receive the full amount of radiation, so you need to put something to build up the radiation. That used to be something relatively simple. You have like a slab of material that's equivalent to tissue that you put on top of the hand that builds up the radiation, but that would give a uniform thickness that would be treated through the patient. So if you want inside the patient to shape the radiation, you can have custom made a compensator that has the opposite shape on the patient. I have no interest in this company other than some pride because it's a Canadian company, but we use a software from Canada that takes that shape that you want to create inside the patient and produces the file to send to the 3D printer. So we've built up a collection of 3D printers in radiation oncology. I think we have 7 or 8 now, and we have the different 3D printing technologies. For this purpose, it's what we usually imagine as 3D printing. So it's additive 3D printing, where you're like melting a piece of plastic and building up the part. But we do have the other technologies as well. So for other circumstances, we make molds instead and then pour in silicone to get a softer print. So the way we function, so all our patients, they used to get CT scan and MRI, but I guess we've been asked to cut down a little bit on use of resources. So now they come, they get a CT scan of their hand. We've drawn out on the patient, plus looked at the CT scan to choose the extent and the depth that we want to treat. In the computer, it takes about an hour. There's the thickness of this compensator is designed. It takes a few hours to print, so usually overnight it prints, and then it not only gives you the depth profile at dose, but also when the patient comes every day, you have a pretty good idea they're setting up their hand the same way because it fits within that mold. And then we can do a CT scan to check that the mold has printed as we had planned initially to print it. And we don't do anything special about the schedule. I think the spacing now between the 2 series has gotten longer, but it's the typical fractionation schemes. So these 3D printed compensators make the whole thing a little bit more involved, but we feel that once we have it, we have a fast and reproducible way to set up the patients. We get more homogeneous radiation distribution within the patient. We give a lower total amount of radiation to the patient, and we use this for other situations, but specifically for these situations, we have a few hundred patients now that we've treated, and we have the workflow down to where it's pretty straightforward and has become our most common way of treating patients. That said, I might be back here in a few years, and you'll be making fun of me, and that this was a very, very fancy iron lung to treat polio or to treat Dupuytren's in this circumstance.
Great.
Yeah.
Maybe just start with Heinrich.
I think we, as radiation therapists at Henschel, should make up a group and forming what should be irradiated. I saw a slide in which you positioned the hand backwards and a bolus on the back of the hand.
No.
This treatment photos is done in USA. I see this in DART. So the full hand gets irradiated. I saw your picture treating the hypothenar area and also the thenar muscle. Thenar and hypothenar muscles should not be irradiated. You may have later on chemotherapy, damaging nerves, damaging muscles. You might want to wear a wheelchair, but you have given 30 gray on these areas. Never ever you get nodules on these muscles. You should not give radiation to the carpal tunnel area. Who knows what is the carpal tunnel? It starts when the creases disappear, and over 2.5 centimeters below, the tendons reappear. And every dose going to this tissue is failed, is not target. And auto voltage is not the worst dose, because it starts 100% on surface. And the target, usually which you treat, ends at 5 millimeter depth. So electrons, and that's the fine and very good thing about your talk, is that you compensate, but you should know when you want to stop radiation, when you want to have the fall off. I don't want to have any dose backside on my hand, letting my hairs disappear.
Sure, maybe misinterpretation of the images.
That's important that we have to agree which is the target tissue. Yeah? And this is apparent between radiation therapists and surgeons.
Well, maybe we'll just take that as a comment. Unless any got
too simple or too complicated? One or the other.
Well, just really quickly, I guess touching on Charlie's point before, that occasionally you do get a bit of edema and swelling after the first stage. Is that something you've ever seen with this very closely fitting bolus, that you've had to redo it at all?
No. The only cases that we replan is, we used to replan everybody, and it was sort of quality control. It's like blinded, you re-pick the area twice, and then to see if we pick the same area, but post-op patients, because we treat them pretty quickly after open surgery, and sometimes a few months later they can open the hand more and they don't have all the bandages, and then we redesign everything. And typically those patients, we didn't do the 3D printed because we used to want to start quickly after the surgery, and this was a little bit more involved process, but it doesn't swell enough that it doesn't fit in those molds.
Well, hopefully you don't have to bring your iron lung to the next meeting. So thanks, David.
All right, thank you.